Hello all. Thank you for joining us this evening. We'll just give it a couple of minutes whilst we let people join the webinar. It's already over 200 of you with us, which is fantastic to see, and the numbers are climbing rapidly. So it's great to have so many of you join this webinar. Just give it a couple of moments. Up to 350, which is fantastic. Thank you for joining us this evening. Let's give it another minute or so. 360 participants joining the call. Fantastic. We're up to 370 people on the call, which is great. Um, so I think we'll probably get going there. So thank you for so much of you joining us this evening. My name is Simon Greaveson. I'm the Assistant Director of Research at Prostate Cancer UK, and it's my privilege to host this evening's webinar where we'll be talking about the Transform screening trial. Um, to mention a bit of housekeeping before we start, we are recording this session, but please be reassured that it's only the speakers that can be seen and heard, so you won't be able to be seen on the recording, so don't worry about that. If you have any questions throughout the webinar, throughout the talks, please do put your questions in the Q&A box. We'll try and answer as many of these as we can do at the end in the Q&A session. So yeah, please do as you think of them, put them in the Q&A box there. But we do ask, please do not share any sort of personal information or personal health information in these questions. If you do want to discuss anything specifically about yours or another's person's health condition, then we've got a team of brilliant specialist nurses who will be able to speak to you and you can go into a lot more details. And the information about that has just been shared in the chat. Um, Also, before we start, we'd just like to do a quick poll, if we may, just to get a better idea of who's in the audience today, and so that we can just constantly and continually improve the content of the webinar. So if you could please respond to the poll, that would be fantastic, and then we'll get going. Okay, I think that's probably enough time for the poll. So, as I say, we've got a really, really interesting webinar today, delving into the Transform screening trial. You'll be hearing from a number of our speakers. Firstly, I'll start off just by way of backgrounds. You'll then hear from Nikhil Mayor, who'll be talking about the details of the Transform study and the day-to-day running of the trial. You'll hear from Dr. Penny Cristinacce, who will talk a bit more about MRI and its role in the study. Then Professor Rakesh Heer, who is one of the leads of the study, and he'll be talking a bit about biodigital twins and the accompanying biobank of patient samples that will be running alongside the study. And last but by no means least, you'll be hearing from Robert Aldroyd, who will be sharing his experience about involvement in the trial as a patient research partner. So that's someone with personal experience of prostate cancer who works side by side with the researchers in the delivery of the research studies, providing that unique input and expertise from that patient perspective. And then finally, as mentioned, we'll finish with a Q&A session at the end. So, if I may start, I've got a couple of slides which will be shared just now. Please bear with. Thank you. So, yeah, so before we hear from the speakers today, I just wanted to give a bit of an introduction and background as to why we need a screening program for prostate cancer and what has led us to the funding of the Transform study. If we can move to the next slide, please. thinking about it. Oh, we need to share again. Were we able to share the slides? If not, I'll keep going and hopefully they'll come up. Um, so yeah, I'll give a bit of background around it. Oh, here we go. So, and then next slide. I think Zoom is playing up for us at the moment. Not to I can keep talking, it's fine. So yeah, I mean, unfortunately, we know, and I'm sure many of you will know, that prostate cancer is the most common cancer in the UK, with more than 64,000 men diagnosed each year. And sadly, that number is on the rise as we have a growing and aging population. If it's caught early, prostate cancer is treatable with effective treatments like surgery and radiotherapy. However, sadly, in the UK, currently around 10,000 men are diagnosed each year with advanced prostate cancer, and so at a stage where it is no longer curable. And we also see huge variations within the UK. So we see there's a significantly larger proportion of men in Scotland, Northern Ireland, and the north of England that are diagnosed with advanced prostate cancer. And that's much higher than we see compared to the south of England. There's also huge variations between ethnicities as well, with black men more likely to be diagnosed at a later stage than white men. Were we to have an effective and routine screening program, this would help to begin to tackle these issues and these inequalities and ensure that we have a much more men have their cancer diagnosed at an earlier and much treatable stage. However, previous screening studies to date have been somewhat inconclusive with their findings. So there have been three significant large-scale screening studies that have been carried out over the past 30 years, which have randomized hundreds of thousands of men to either be invited to a screening program with a PSA blood test or to not undergo screening, so otherwise known as a comparator control arm to the study. And these three studies all produce different results. So, firstly, the UK-based CAP trial demonstrated that screening with a one-off PSA blood test leads to a modest difference in reducing the number of deaths from prostate cancer, but that this came at a significant cost through the detection and treatment of many low-grade cancers, which would have never gone on to cause any harm, and resulting in many men experiencing long-term side effects from their treatment, such as incontinence and erectile dysfunction. Meanwhile, the ERSPC trial, which was carried out across several European countries, showed that with repeat PSA blood testing, it made a significant impact in saving men's lives. But they too saw a significant number of men with these low-grade cancers being detected and treated as a result of screening with just a PSA blood test. And then thirdly, the US-led PLCO trial, which was carried out around the same time as the other two trials, showed that screening made no difference at all. And they also saw many low-grade cancers being detected and treated. It is thought subsequently that there might have been a very high rate of PSA testing amongst the men in that control arm of that study, meaning that there was actually very little difference between the number of men getting tested in the screening arm and in the control arm of the study, which would significantly influence and plenty compromise the results there. So a bit of a mixed picture from those previous studies that we've seen. But we know that the way we diagnose prostate cancer today has advanced significantly since those studies, with the introduction of MRI, improvements in how we biopsy, improvements in treatments, and also increasingly the use of monitoring for these lower grade cancers through what's called active surveillance. And you may hear a bit more about some of this from the other speakers shortly, I think particularly around the role of MRI. So really, this is where Transform comes in. I mean, over the past 20 plus years, Prostate Cancer UK has been supporting research into the developments in the way we diagnose prostate cancer. So we funded early stage research into the use of MRI before biopsies, and also research into the discovery and development of genetic markers, which might increase a man's risk of developing prostate cancer. and through to launching our very own 30-second risk checker, where men can quickly and easily find out more about their individual risk of prostate cancer based on their age, ethnicity, and whether they have a family history of the disease. So back in 2022, we brought the research community together and discussed what research is needed to generate the definitive evidence to support a national screening program for all men. And from this meeting, the early designs of the Transform study were formed. The resulting study was then submitted to us for funding, and this was rigorously assessed by an international committee of leading prostate cancer researchers and clinicians. And it was towards the end of 2023 where we were able to finally confirm funding for that first phase of Transform. Now, after a lot of legal and regulatory discussions and approvals, we're now really thrilled to start seeing men beginning to take part in the study. And you'll shortly hear from the others that this is a huge endeavor and one we possibly couldn't do alone. And so it's really with thanks to our founding partners and major supporters who so generously contributed towards the funding of the study, as well as the academic partners responsible for the delivery and management of the trial as well. So that's enough background from me. I will pass over now to Nikhil Mayor, who will tell you much more about the study. Nikhil.
Fantastic. Thank you so much, Simon. I'm hoping some slides have appeared on the screen for you.
Yes,
Um,
you can see them. Yeah.
Perfect. Great. Well, thanks so much for the background and introduction. I'm going to just continue from there and give a bit more of a background to Transform itself, and then talk about the study, its design, and where we're up to. So my name's Nikhil. I'm a trainee urology surgeon in London. I'm taking some time out of my training now to do a PhD, and it's all focused on Transform, delivering the study. That's my day to day. So I know the trial inside out, and we're doing everything we can to get as many men as possible involved in the study. So a little bit more on the background of why we really need a trial like Transform. As Simon alluded to, screening with the PSA test alone, it can detect cancers earlier. We know that, and it can save lives. We've got really good evidence from some of the older studies that started 30 or 40 years ago. But it's not accurate enough as a sole test to not only save lives but reduce harms. So two-thirds of men that have a PSA test, it will be falsely raised. So it'll be raised for a reason other than prostate cancer. And as a result, in the older screening path, the older testing pathways used to have, it could lead to a lot of unnecessary and quite often invasive tests. We now know that actually it can even miss some cancers. So people with what we thought was a normal PSA could also be living with prostate cancer. One of the main issues with PSA, on top of the fact that it's falsely raised in lots of cases, is that it can detect small cancers. Then we call these low risk cancers, that sit within the prostate, and they don't really grow. They're unlikely to ever cause any symptoms, to spread outside of the prostate, or in fact impact a man's life. And in the worst case scenario, men with these low risk cancers could be offered treatment, which they don't really need. And we call that over treatment. Um, Treatments often come with side effects, and some of these side effects can be really life changing, and last for the whole of a man's life. So we want to avoid that. And as a result of all of these problems with the PSA test as a sole screening test, we don't have a screening program in the UK, but we know that we probably need one in order to some of the 12,000 lives that are affected every year. The UK National Screening Committee is an arm's length body from the UK government that assesses all of the evidence. They last reviewed it in 2020 and felt that there wasn't enough evidence to recommend screening. And they're currently assessing the evidence once again, and we're hoping to get some outcomes from that review in the next couple of weeks. So to transform. Um, Transform is taking place in a number of stages. The first stage is what we call a pilot study. We're going to look at several different interventions, which I'll touch on in a moment. And we're going to see how we can best deliver these interventions and which one might be the most effective for screening. So, which one will have the highest benefit and the lowest harm. That will last for around 3 years and test 16,000 men across 10 or so sites around the UK. And we're proud to say that we started that in November of last year, and we're well on our way. And we're starting to open at other sites now as well. Stage two is the main study. It's a much larger study. In screening, you have to do really large studies to get the outcomes that you need to make a decision about prostate cancer screening. And so that's going to be 300,000 or so men. And we hope to start that in a couple of years' time. We'll recruit for a period of around 4 to 6 years. And then the next step is follow up. We need to see if doing screening with the tests that we recommend, compared to not doing screening, really saves lives, and doesn't cause too much harm. So we will have some results in a couple of years from the pilot, and then it'll take a little bit longer to get the results from the main stage of the study. So who will be invited to transform? The prostate is a gland that's only present in men or people that were born male. We're going to invite men aged 50 to 74 as we think this is the group that's most likely to benefit from screening. Prostate cancer is uncommon below the age of 50 and very rare below the age of 40. However, some men are at increased risk. So, for example, men of black ethnicity are known to have a higher diagnosis rate of prostate cancer and possibly likely to develop more aggressive disease. So, we want to catch prostate cancer slightly earlier in those that have a higher risk. So, we'll invite men from the age of 45. We also know from lots of research that those with learning disabilities are often affected worse by cancers and have poorer outcomes from all types of cancers. So we're going to invite those men at a younger age. We're not going to invite men that already have prostate cancer, as screening this group won't be of any benefit. And we're not going to invite those that have already been tested or screened in the last 5 years. Having a recent urine infection is known to increase artificially the PSA level, and also can affect some of the downstream tests that we do. So any man that's had a recent urine infection won't be included. However, they could be included after that settles. And finally, we're going to invite men who are most likely to benefit, and these are men that are likely to live at least 10 years or so. So what are the interventions or the prostate health checks that we're going to compare in the pilot? As I mentioned, the PSA test is a really good test that can save lives, but we know that it causes harm. So we are going to use the PSA test in our first intervention. However, we're going to add in a prostagram. A prostagram is a 10 to 15 minute MRI scan that doesn't involve any injections or any probes. It can be done in a mobile scanner in an Asda car park, or it can be done in a community setting outside a GP, or even, as we most commonly do them, in hospitals. So those that have a PSA above a threshold of 3 will be recommended to have a prostagram MRI, and we're going to do most of those out in the community. We're coming to the communities where men live. We don't want to make men into patients, so we're doing as much of the testing as possible in the community. And then men who have a suspicious scan, if there's anything that they we identify on the prostagram that needs further investigation, we'll offer a biopsy. And this is usually done under local anaesthetic at your local hospital in the urology department, and involves taking some samples directly from the prostate to diagnose or to rule out prostate cancer. As I mentioned briefly earlier, there's emerging evidence that the PSA test could miss some cancers. So in arm two, we're going to look at a lower PSA value of 1. And again, those that have a PSA above 1 will go on to have a prostagram and then a biopsy if required. In the third arm, and this is really quite a novel approach, we're going to offer a prostagram to every man in that arm, so regardless of their PSA level. And if we see something on the prostagram, we'll offer a biopsy. And then this is quite similar to what's done in breast screening, with imaging leading the screening program. And then finally, arm four is really precision screening. So in arm four, we're sending men saliva tests so that they can do them at home. They can send them back to us. And we test over 400 of the common gene mutations to provide a risk level. And we call that a polygenic risk score. Um, that risk level will essentially tell us what is the likelihood of a man developing serious or lethal prostate cancer over the next 10 years. Those that have a higher risk will again be recommended to have a prostagram scan and a targeted biopsy if needed. So the prostagram is very much a novel approach. We use MRI in the secondary care setting at the moment for prostate cancer diagnosis, but it hasn't been used in a big screening study before. And Penny will come to talk about that in a moment. Uh, as I mentioned, the polygenic risk score is really precision type medicine. It's been shown in lots of other studies so far that it can diagnose prostate cancer, but now we want to see if it can truly save lives. So this is the map of the sites that we're aiming to include in the first stage of Transform. Um, it's much smaller than the main phase of the study. So when we start the 300,000 men that we want to invite, that will be across all four UK nations, and will hopefully include lots of men from rural coastal regions, more and less deprived regions, to really get a good sample of men across the UK. So what are the special things that we're doing in Transform? Firstly, we're making Transform an invitation only trial. So unfortunately, men can't express their interest or volunteer to join the study, and that's because we really want to control and make sure that we've got the right sample of men in our study. As I mentioned previously, being of black ethnicity is what we call a risk factor for prostate cancer. Um, in the UK, the proportion of men in the general population that are black is somewhere around 4%. But in Transform, we're going to over invite from the black community. So we're going to invite, so of those that we invite, 10% will be black. We're also going to target more deprived regions, rural regions, and coastal regions. And we're testing a novel trial design to make sure that we get as many people as possible that we invite taking up the invitation, and reducing something called contamination, which Simon touched upon briefly earlier. In screening studies, you want to compare a group that has a screening test to a group that doesn't have a screening test in order to show a difference between the two. Contamination is where men that are in the control group, so that aren't offered screening, they go to their GP and they have prostate cancer screening. So, for example, a PSA test. if you test two different arms that have both been screened, you'll never see a difference. So our main aim is to reduce the number of men that are in that control arm that go on to have testing. We're working with national bodies and local bodies, with individual GPs, and then with NHS England and other alliances to ensure that we have a targeted approach to all different communities. And we have a specific subgroup of our team called the Behavioural Sciences team to ensure that we're really reaching out to the communities that are most likely to be targeted for Transform. And finally, before I hand over and finish my presentation, one of the most important things with prostate cancer screening is that we try to limit harm. There are lots of modern therapies for men that do get diagnosed with prostate cancer that can limit harm, and one of those is something called focal therapy, which is where you target areas of cancer within the prostate without treating the rest of the prostate. We know that that can reduce some of the side effects of screening. So we're saying that only hospitals that offer focal therapy alongside the other traditional treatments can be included in the study. And this is a very confusing infographic that just shows how complex the trial design is. And I'm not going to run through it, but just gives you an idea of all the different things that we're doing and thinking about within the study. So I think I'll leave it there, and then I'll be around to answer some questions afterwards as well. Thank you.
Thank you, Nikhil. Pass over to Penny.
Thank you very much. Let me share my slides. So hopefully everybody can see those. So yes, my name is Penny Cristinacce, and I'm the MR Core Lab Manager working at University College London. And I'm going to talk to you today about the imaging component of the Transform trial. So what we're going to do is just whiz through what a prostagram MRI scan is, as Nikhil mentioned, and talk a little bit about how we can make sure we're getting good quality images all across the country as part of the trial. Then we'll go on to talk a little bit about the radiologists and what they're looking at when they receive the images and how they're reporting on them. And then I'll finish up with a bit of information about the research we might do in the imaging arena as we move through the trial. So MRI, or magnetic resonance imaging, is a method by which we can take images inside the body of our tissues and organs. And it involves getting in a large magnetic field, big powerful magnetic field, and using radio waves in order to create these 3D images of the body. And a prostagram MRI specifically is an image of the prostate. And as Nikhil said, it is a fast technique under 15 minutes where we can get non-invasive images of the body. And so it's really, unlike some traditional tests that can be long and uncomfortable, it's just a quick check that we can fit into your day. And importantly, there's no needles or preparation involved in this. We can get these images without any contrast agent or anything like that. All we need to make sure is that you're safe to go in the scanner and there's no ferromagnetic materials that can make it unsafe to go into a large magnetic field. And as mentioned, in the first stage of the Transform trial, all arms lead to a potential prostagram scan. So it's really key part of the trial to get this right. So what we're showing you here is a few example images that we get as part of a prostagram scan. The two images on the left are images of structure. So the radiologist looks at the different grey levels within the prostate and can assess whether or not there's anything within that image that is of concern. The images on the right are images of water movement or motion, and we call them diffusion images. And although they're a little bit harder to interpret, they reflect how readily water can move around within the cells. So we know that in cancer cells compared to benign tissue, there's changes in how easily that water moves around, how related to how packed the cells are. And so that combination of these two types of images is really what allows the radiologist to make their assessment of for screening. And a lot of research has been done to show that these faster MRI scans are just as accurate at assessing for prostate cancer as those that involve the addition of contrast agents that's sometimes used in a diagnostic setting. But of course, there are challenges involved when we are imaging at scale. This trial, as mentioned, is going to be involving thousands and thousands of people across the country. And so one of the things we need to ensure we can do is have access to MRI scanners in the places that we need them. And so this can be either access to static scanners, so those that may be in hospitals or community diagnostic centres, or scanners on wheels, so mobile scanners that can be moved around to different locations, say be that remote locations or just targeting communities where we need access. And as we move through the trial, these smaller number of scanners will obviously have to increase, so we're getting access all across the 4 nations of the UK. And that comes with some challenges. It requires us to work with lots of different scanner manufacturers and also different magnetic field strengths in order to get access to the equipment we need. And that has some technical challenges because they can give slightly different images. So we need to make sure that we're getting good quality data wherever we're doing it on whatever equipment we're working. So our aim here is really to be able to set up these fast, reliable imaging protocols wherever we are and get good quality data. So whether or not you have a scan in Newcastle or London, you get just the same accurate results. And we need to make sure that we can get the data from where the scanning takes place transferred to the radiologists for them to be able to interpret and report on the data. So one of the challenges is making sure we can get the data that's acquired at the scanning site securely transmitted to the reporting workstations for the radiologists to make their assessment. And then this verified report can be transferred to the Transform team and can get the screening results back to the participants as quickly and efficiently as possible. So one is really key is getting those expert eyes on every scan, and we have a trained team of Transform radiologists who are going to be assessing the images as they come in. And we've got a slightly different way of working than in a diagnostic setting in this screening setting, because we want to make sure that we're getting the right people to the biopsy. And so we're using the stage-gated approach. That involves the 2 radiologists looking at a structure image and a water motion image and assessing whether or not they can see any areas of concern on those images. If those 2 radiologists agree that there's nothing of concern, that is a negative screen and there's no need for any further review. However, if those 2 radiologists see a dock area on one of the images and a light area on the other image, as evidenced by these red arrows, then that is a screen positive at this stage, and it is then going to be reviewed by a 3rd radiologist who will have access to all the MRI scans and be able to make an assessment as to whether or not that person should move towards biopsy. So as we move through the trial, it's really key that we're trying to improve things as much as possible as we go along. And so some of the questions we want to ask in terms of the research as we move through the trial are these. So one thing that's really key is that we can try and get the image right first time. And so we're working very closely with the scanner manufacturers in order to improve the on-scanner quality control. We know that images can be affected by motion, so people wiggling around, also bowel gas or implants such as hip replacements can all affect the quality of the data. So what we want to do is be able to assess readily and quickly if there are any tweaks to the protocols, any tweaks to the imaging that we're performing whilst that person's still on the scanner that will allow us to get images that can be read by the radiologists right there while they're on the scanner. So this is ongoing work that we're involved in. The other key question is who needs a biopsy? We know that in a diagnostic setting, half of the people that are undergo biopsy do not have any significant disease. And so if we look at these cartoon depictions of benign tissue on the left and cancerous tissue on the right, we can see that the kind of underlying microstructure of the cells, there's smaller areas of white, this lumen here in the cancer, and larger areas of purple, so the epithelia. And we've got methods within research community for MRI that can really target how much of these cellular characteristics we have within the tissue. And these have shown a lot of promise in being more specific to who needs to go for the invasive biopsy procedures. And so methods such as luminal water imaging and verdict MRI are in development and can potentially be tested within a screening setting. But of course, we are living in the world of artificial intelligence, and so it makes sense for us to ask how AI can help. And there are ongoing research projects that can look at how AI might be able to help us decide in that decision to biopsy, help us in triage and deciding quickly and identifying healthy results. And lastly, as an additional pair of eyes, so as a support to the radiologists when looking at the scans and supporting them and being able to potentially reduce the costs involved in having lots of radiologists reading these images. So that's the research side of things. And so I'm just going to thank you for your attention for now, and I'm going to stay around and answer any questions you have later. But really great to be involved in this really exciting trial, and thank all my colleagues that have been involved in the Transform project. And I'll pass on now to my colleague, Professor Rakesh Heer, who's going to tell you all about the exciting work that's been done as part of Transform Discovery. Rakesh.
Penny, thank you very much. And I'm delighted to be here to be talking about a really important part of the Transform screening trial. It's something we're calling Transform Discovery. And this important program at the heart of it has the development and the establishing of the National Prostate Cancer Biodigital Twin. You might ask, that's a bit of a mouthful. What does that really mean? I'm going to explain that in the subsequent slides, but for now, we'll call this a state-of-the-art biomarker testing machine. When we were first pulling together the trial, the leads were keen to maximize this amazing opportunity we were given. It's a once-in-a-lifetime opportunity, and the chance to collect tissue along with bringing patients into the trial with the 4 biomarker strategies that you've been hearing about from former presenters, we realized would provide an opportunity for further testing. We can look at other biomarkers in this space. We wanted then to develop a biobank. And as I spoke to various stakeholders, other clinicians that have endeavored to do this work before with other very important clinical trials, including the CAP study and PROTECT, it became clear that we needed a very, very different process to what I had done before. Previously, people had simply taken tissues and put them away. What we wanted to do here, and this is something that we heard from patients, was to get something that can give us answers quickly. So we pulled together a design for a powerful flat platform where we are interested in rapid assessment and development of biomarkers. We also wanted to have one eye on the future because we can do some biomarker testing of those that are in the current biomarker arena. But of course, technology is advancing all the time, and over the next 2 or 3 years, we'll see new tech arrive. There'll also be new tech arriving in 6, 7 years from now that we have no idea about. So we wanted to have a platform here that was fit for purpose, providing infrastructure for decades of testing. Another thing that we heard from scientists who want to access biobanks was that they felt that they weren't always able to get to the biobank, or when they were able to get access to the biobank, the types of tissues that were stored or the way that they were stored wasn't appropriate for them. We were very keen to address that. We've designed a biobank for users. We're not looking here to archive and to wait for the data to mature. We're very keen to start biomarker testing as soon as possible. And with that, we are living through this notion of a live biobank with real-time data moving in and out. The avant-garde description that we were looking for was a biodigital twin. We'll talk more about what a twin actually means shortly, but for now, we'll start fleshing out the idea of what this biobank involves, and that is biobanking of biospecimens, but additionally bringing together digital information as well, and digital banking, and hence biodigital banking. We're going to end up having a huge amount of clinical data, as you've heard, 300,000 men. And as we work through those that end up having scans, those that end up having biopsies, those that then can consent to provide blood samples, urine samples, tissue samples from additional surgeries, we're going to end up with a huge cohort of material here linked with clinical data, and this data is going to mature, linking with clinical treatments and longer-term clinical outcomes. We're not keen on collecting tissue for the sake of it. We're really, really motivated about making a difference for patients in the foreseeable future. What we're thinking about is the entire pathway. Transform is about screening before we have symptoms, asymptomatic men, but there may be roles for biomarkers in those that start having early symptoms. We can pick up a potential cohort of men that have significant prostate cancer in that space. We're interested in understanding how men move through investigations and diagnosis and how biomarkers may help there. Longer term, we're interested in understanding how treatments might work better, and of course, living beyond treatment as well. Here, we've got a long list of different types of biomarkers. They can be predictive, diagnostic, prognostic. They can be stratifying, allowing personalized medicine. They can be companion biomarkers to look at how well treatments are working. They can be therapeutic biomarkers, helping select for certain types of treatment. Some men might do better with radiotherapy as opposed to surgery if they have localized prostate cancer. If they're having various treatments, chemotherapies, for example, there may be ways of looking at safety. In the longer term, there may be better biomarkers for monitoring and looking for recurrence at an early level to treat to get better outcomes. Of course, much of the focus right now is on diagnosis. We're going to talk a little bit more about this notion of a living biodigital twin. And here, what we're looking to do is split the tissue collections. So when a tissue sample arrives from one individual, for that individual, we're going to split the tissue collection into a long-term archive, but also tissues that will be used for real-time testing in the foreseeable future. That would allow real-time updates on how good these biomarkers are working. What we're doing is we're speaking to a number of biomarker companies. There may be multiple examples that you're aware of that you've read in newspapers. Hardly a week goes by without a new company declaring they found the best test to diagnose prostate cancer. We're in advanced negotiations with a number of stakeholders who might want to take their work forward, and they are almost certainly going to be moving forward in the next few months. We've had over 60 expressions of interest. So we've got a really great opportunity here, allied to the clinical trial, to undertake some rapid biomarker testing that would allow two things. One is to understand which biomarkers are good, so we can clean out the ones that are good and those that aren't fit for purpose. And those that are good, if further evidence is required, we can bring them into the clinical trial itself. I'm going to talk about twins, digital twins. This is, if you like, next generation modeling. Industry standards now in manufacturing and engineering involve the creation of biodigital twins. Here's an example here of a twin for the aviation industry. We've got an airplane, and what happens is that that physical entity is studied in huge resolution, collecting as much information as possible to create a virtual representation, a computer simulation. So we end up creating this identical twin that mirrors the physical world. And what we can do here with that model is we can simulate the effects of various interventions. And in our case, in the biodigital twin, the effects of using a biomarker or certain treatments. Historically, it's been a challenge, but big data is something that we can handle well now with advances in computing power. So this is the opportunity that's afforded by digital twins. It allows us to undertake multimodal complex data analysis. What we mean by that is that we can now look at not just one biomarker, we can look at whole genomes, the entire human genome for an individual. That's 6 billion data points if you do full sequencing. We can then integrate that with the conventional clinical outcomes, such as treatment outcomes. We can also integrate that with the imaging that we've just seen Penny talk about. We can integrate that with the pathology. The technology is now ripe for scaling into medicine, and our study here in prostate cancer will be an excellent test bed for that. As patients move through their natural history of having certain treatments, following certain types of diagnosis, advanced disease, localized disease, locally advanced disease, and so on, there are natural experiments that will come into existence as we follow our patients through over the next few years. And those natural experiments allow us to identify controls and experimental arms that we can make some comparison of and inform our clinical practice. We're using real world data, so that provides huge amounts of power. We know that in clinical trials, we can sometimes inadvertently create artificial situations that don't always translate perfectly into the real world situation. And as you've been hearing, we've got individual testing, and we now have the potential to scale that up to also study what happens on a populational level for informing service design. You might think that all of that's sci-fi, but actually it's stuff that we do all the time. Here's an example of a clinical trial, the follow-up study. It's another study that I'm involved with. And here we're looking at 100,000 men's routine registry data that's collected as part of hospital admissions. And we've got follow-up getting on to over 7 years. And we're undertaking these natural history experiments using conventional epidemiological approaches. And what the twin would allow us to do is to take this methodology and to elevate that to provide that multimodal integration. So in summary, we've got this ambitious, powerful platform as an adjunct to the clinical trial. We'll be able to undertake rapid biomarker testing, go through a whole suite of biomarkers, and if there are tests out there that are ready, fit for purpose, we're going to know about them very quickly. We're also supporting those translational studies where they've made some discovery of a new type of biomarker, a new process that might be relevant as a biomarker, and we can help them with those early steps to generate some validation data. we'll be able to simulate health technology assessment at scale and at pace, and we'll be able to undertake cost-effective analysis, helping inform NHS and NICE about the value of those tests to our national service. Thank you. Right, I'm going to hand over to Rob, and I look forward to taking questions in the Q&A session shortly.
Thank you, Rakesh. Good evening. My name is Robert, and I'm speaking to you as a prostate cancer survivor about Transform, and which of course is generously sponsored by Prostate Cancer UK. That's to say, by people like you. I was diagnosed with prostate cancer in 2003, 23 years ago. After a PSA test and a biopsy, I had my prostate gland removed via open abdomen surgery. These days, I'm glad to say prostate gland removal is performed in most cases by keyhole surgery, considerably reducing risks and the recovery time. And to check prostate health, I'm pleased to say that nowadays a suspicious PSA leads to an MRI scan, and then only if it's needed, a biopsy, with a much higher degree of accuracy than in 2003. Most men have side effects from their treatments, and most treatments have side effects. In my case, several months of temporary urinary incontinence, but unfortunately permanent erectile dysfunction. And despite much research since then, many men still suffer similar after effects. But the fact is, I'm delighted still to be alive 23 years later and able to continue and enjoy a very active life indeed. So why do we need the Transform trial? Well, despite greatly refined methods of diagnosis and treatment, far too many men are still dying from prostate cancer, often because they're diagnosed too late. And I'm delighted that current discussions about diagnosis point clearly in favour of screening men for prostate cancer. And that is precisely what Transform's about. If it's successful, it will make a huge difference to the life of every man. Most members of the trial management group are brilliant and dedicated medics and scientists. You've heard from some of them this evening. But two of us affected by prostate cancer represent public and patient interests in the research as co-researchers, not as an afterthought. If the experts propose a procedure that we feel patients won't tolerate, or that's unlikely to benefit them significantly, we insist that it's changed, and it is. We also make sure, rather importantly, that information for patients is in everyday language, in words we can all understand. And trial management group leaders put a high value nowadays on the contributions of patients and the public. It's especially important that participants in Transform includes Black men who, for reasons not yet understood fully, are 2 or 3 times more likely than white men, not only to develop prostate cancer, but for it to be more aggressive. And one of the strengths of Transform is that men of all ethnicities and disabilities are included in the trial and geographically distributed in order to ensure a true reflection of the whole population. Now, as you've heard, the full trial is going to take a number of years. However, early findings available in a couple of years' time may help us to make the breakthrough so desperately needed, providing vital data that finally tips the balance in favour of life-saving screening for thousands more men. But, there's always a but, none of this is achievable without substantial financial support. Research is very expensive, and Transform is especially so. And without generous supporters like you, research and improved prospects for men with or at risk of prostate cancer would simply not be possible. Transform is desperately important for the health, well-being, and peace of mind of men and their loved ones. as a patient representative and a co-researcher, I thank you from the bottom of my heart for your support. Thank you very much for listening. Back to you, Simon.
Thank you, Robert, and thank you to all of our speakers. Really, really fascinating talks. We've had lots of questions come in through the Q&A box. Please do keep them coming in. We're slightly overrunning on time, so I think if there's any we don't get to, we will try and get back to you with them after. Um, Before we do, and a nice link there for what Robert just ended on, I wanted to talk a little bit around gifts in wills. And I mentioned in my bit at the start around the funding that we've received towards a transform study to date. And in fact, £1 million of that has come from gifts in wills. And more broadly, 1 in 4 of the research projects that we fund as a charity are supported that way. So it's a real, really important source of donations to the charity to enable us to do what we do in research and more broadly. So if you are interested in leaving a gift in your will, there's a link that's been put in the chat to give you a little bit more information there. Okay, I will I might group some of the questions together just for time. There's been a few just touching upon this might be for Nikhil, perhaps around when is recruitment taking place and how will men be contacted? And I guess what should men do if they have symptoms and they're not invited to take part in the study?
Perfect. Yeah, I'm very happy to answer that. So, recruitment for the pilot has commenced. It will continue to run for another 18 months to 2 years across several centres across the UK. At the moment, we have opened predominantly in London, but we are looking to expand to the southwest to start with, and then moving up north and then across to further to the east as well. We're going to open in a staged approach, so we'll take one site at a time and recruit somewhere between 1,000 and 1,500 patients or men from each site. If you receive a letter in the post, we strongly encourage you to take part and contribute to this important research endeavour. It will be initially a letter, and then later down the line, if you have an email address, you may receive an email reminder or a text reminder. In terms of if you are suffering with symptoms that you think may be related to your prostate, we encourage you in the first instance to seek help from your local GP, and if they feel it appropriate, they will refer you to your local urology department. One other kind of thing to touch upon is that we know that in the vast majority of cases, prostate cancer doesn't cause symptoms, and men that do have symptoms, it's not generally related to a prostate cancer. But if you are worried, please do see your GP.
Thank you for that, Nikhil. And so I think, yeah, just to pick up on the timeline. So with the stages that Nikhil presented, we're having recruitment happen over the next year or so, with some initial results coming out from the study from that stage 1 within the next couple of years, which will give those sort of initial results, and then we'll be scaling up into that larger scale stage 2. I think we've had a few questions around the timeline, so just to clarify around that. We've had a question come through. I don't know who might want to pick this up, but it's just asking, does any other countries have a screening program for prostate cancer? And do we know how effective they are if they do? I don't know if anyone wants to wade in on that one.
I'm happy to very briefly touch on that, and then perhaps Professor Heer. There at the moment, there isn't any country doing formal population level screening. Lithuania has been doing some pilot work over the last 20 or so years, since 2006. In Europe, there is a large initiative going on across 5 different regions called Praise You, and they're testing several different screening strategies, but it's not a research study. They're looking at how they can implement screening across these different regions, and some of the early data from those regions is starting to come out, but we don't have any long-term outcomes.
Thank you for that. We've had a question. This might be one for you, Penny. So it's asking about how Transform relates to some previous studies that have gone before. I think that are MRI focused. So specific mention to the LIMIT study and the HistoMR study. Maybe could you just sort of talk a little bit about how it's building upon evidence that's gone before?
Yes, of course. So yeah, there's a lot of studies that have kind of led up to where we are today, and some of these are looking more specifically at whether or not a biparametric approach, so just using the structure image and the water image for diffusion, can allow us to assess prostate cancer, or whether or not we need to be using a contrast agent as well. Touching back on the LIMIT study, as you mentioned, that's looking specifically at luminal water imaging, which is a method that allows us to look at the lumen of the tissue. So it's a quantitative method that has been developed and it is being used as a screening tool. And we are have been doing that imaging in the community at the moment. So recently that we've had a mobile van sitting out near West Ham Stadium, where we've had people being able to come up and actually have a screening session in that MRI van at that point. And so a lot of these studies, as you say, are really moving towards what we're able to do in that screening setting. And we're hoping that a lot of that work that's been done and has been done previously will be able to feed into and improve the imaging that we're doing as we move through the trial. And we will continue to use that research base as we develop the work and move forward.
Thank you, Penny. And perhaps one for you, Rakesh. There's, I think, been a lot of love for the biobank and the biodigital twin in the Q&A box, which is fantastic to see. Could you touch on a little bit around the steps that have been taken to protect individuals' data in the biobank? And I think you've touched upon this a little bit, but already in your talk. But given that Transform's running over a number of years, how the program will incorporate new innovations and new technologies as they emerge.
Yeah, so the timelines for delivering a biomarker test in the platform, the twin platform, is really quick. We can turn that around within 6 to 12 months for most of our companies. And what we're looking to do is report independently. So when the companies come in, they essentially are helping us with the tests, but what we're doing is we're reporting the test, we're doing the linkage, and that then talks to the first question, which is around how secure the data is. It's firewalled. They have no access at all to any identifiable data. And what we'll do is, for an individual, we will link them using a pseudo anonymized link, so just a long serial number, and we allows us to do the test, and they tell us what the test result is positive or negative, and then we take that back, nothing to do with them, we do the linkage, and that way you can be absolutely sure your data is safe.
Thank you. A question for Robert. So it's good to hear that the views of trial management groups, the patient view within trial management groups are taken seriously. Has this always been the case over the years you've been involved? And I guess to add a question for myself as well, what motivates you to be involved in research as a patient representative?
I think I can safely say that over the last 20 years or so that I have been involved with work of Prostate Cancer UK in the research area, that I have been taken seriously. I think there have been one or two more or less anecdotal cases of trial management groups not particularly welcoming input from patients, but I think those are rather in the past rather than present. And in any case, when you get to the research ethics committee, that every proposal has to go through, they look for patient involvement as well. So if you're not involving patients, you don't get passed. As to why, I've never asked that question really, except for a long time ago. I worked in academic libraries for all my life actually, and used to working with academics and especially medics and researchers. And it seemed a logical thing to do, having been successfully treated for prostate cancer, to a means of putting something back into the system and making things better. And I have to say that developments over the last 20 years have been astonishing. And I'm only sort of envious that I probably perhaps won't be here for the next 20. Who knows what you're going to discover.
Thank you for that. We're moving through to some other questions as well, conscious of time. There's a question about what's the reasoning behind targeting coastal communities? I guess the same will be true for rural communities as well. What's the rationale for targeting those particularly?
Yeah, so perhaps I can answer on that. We know that certain regions and communities across the UK are less likely to uptake in certain screening programs. We've learned that from other screening programs in other disciplines, and therefore we really want to target those areas and ensure that we've got adequate representation from those groups so that they don't miss out.
Thank you. And also then picking up on the point around focal therapy, do you know sort of how many hospitals are offering focal therapy at the moment, and is it likely that this is being sort of expanded in the near future?
Yeah, so I think there's somewhere around 9 or 10 centres in the UK at the moment. This is expanding. There are several sites across all four nations of the UK that have expressed interest and different regions that are putting in business cases to their local hospitals to get focal therapy up and running. And we think within the next year or two, this could possibly increase quite rapidly.
Thank you. And about the polygenic risk score there's a question about could this be done at a younger age? It seems like a very easy test for individuals to do. Is there merit in doing it earlier, or why have we chosen the age groups that we have done for the study?
Yeah, it's a difficult question. I mean, most of the testing for the polygenic risk scores has been done in those older age groups, or not older, but say 50 and above 50, because we know that prostate cancer is more common as we get older. Age is the number one risk factor for prostate cancer. So doing it in a very young man, their 10-year risk of developing prostate cancer is likely to be quite low. Um, I don't know if anyone else in the panel wants to elaborate.
Yeah, I'll add to that. I mean, essentially, you're born with that risk. You can take it as a neonate, and you'll know. It's just that it doesn't mean you're going to get it. It just means you're at higher risk, and then you need to correlate it with when you get it, and you have to wait, I'm afraid. So I do agree with that being a really interesting question, and perhaps opens up this paradigm that some men end up having selective higher intensity testing occurring at an earlier age based on that. But for now, I think we need to validate what the studies have shown in an age where prostate cancer first presents, that those polygenic risk scores are indeed robust.
Thank you. And can I ask, so what's the advantage of exploring four different screening tests within one study? Maybe Rakesh, coming back to you as one of the
Yeah,
leads.
it's interesting because it's incredibly expensive to do it. It's incredibly expensive to do a study to run over nearly 10 years. And because it's expensive, we need value for that. So we can't go in with one strategy and then find that a new strategy and iteration of that comes in that's proven to be better. We're hedging our bets. So what we did is we looked at the very best compelling data out there for the strategies that are likely to make a difference. They've reached a threshold and they then are being tested in parallel. It's a great way to deliver efficiency And as other tests emerge that show equal promise, having gone through those first checks of showing a positive signal, I think there'll be a chance for us to also add additional arms and adapt in time.
Thank you. And we are reaching the end of the questions, so maybe one last question to you all. What's most exciting to you about Transform, and what are your hopes for the future that it will bring? Don't know who wants to go first.
Maybe I'll jump in first, actually, because I think the other people are probably going to go towards the prostate screening. But for me, as an MRI physicist, I moved into this area from a chemistry background in order to try and make an impact in people's lives, and to be involved in a trial where imaging is, key to delivering a result is just so exciting. And so it's great to see MRI up there, hopefully answering the questions that people have.
I'd add that the single biggest opportunity we have to change outcomes for men with prostate cancer is early detection. We are really privileged to be involved with such an important study. And personally, for me, I think I'm absolutely thrilled that we're going to be making a big difference for not just men in the UK, but for men around the world.
Perhaps I
can't,
can. Oh, go ahead, Robert. You go
sorry,
ahead.
Nikhil. I can only echo that, really. Rakesh, you put it so well. I've been involved in other imaging trials run by Imperial College with Prostate Cancer UK funding, and it's wonderful to see all these sort of come together in the Transform study. And I jumped at the opportunity when I was invited.
From my side, just one of the pioneering elements of Transform is that we are inviting 10% of the men we invite are black. If you look back at the really big screening studies we've already done, that population was really not included or targeted in any way. So I think we've got a really valuable opportunity here to impact a group of men that we know can be affected or be worse off when it comes to prostate cancer diagnosis.
Thank you all. And so just to conclude from myself, so thank you all to the speakers, Nikhil Mayor, Dr. Penny Cristinacce, Professor Rakesh Heer, and Robert Aldroyd. It's been a really, really fascinating webinar, so thank you for your time this evening. Do keep an eye out for our next webinar. It's going to be take place on the 1st of July, where we'll be talking about the Intensify trial, which is investigating whether we can tailor treatment for men with advanced prostate cancer, and whether the earlier use of chemotherapy alongside hormone therapy in combination can be effective for certain men with advanced disease. So really, really interesting study that's launching later this year. As I mentioned earlier, if you do want to learn more about leaving a gift in your will, please do look at the link that was posted in the chat. All gifts we receive are very, very greatly received and allow us to do exciting research like this. So we really do appreciate your support and your time. And just to conclude, we have one final poll. We just would like to get your initial thoughts and reflections and feedback about the webinar. There will be the answers will be anonymous. So yeah, we welcome your feedback so that we can help shape these in the future. And there'll also be another opportunity afterwards. You'll be sent a post-event survey, which you can provide any further thoughts that you may have. So just give a moment to complete the poll if you've not done so. And that is all for the webinar. Thank you so much for joining us. I hope you've enjoyed the discussions, and we look forward to you joining us next time. Thank you very much.